Hello, doctor. How are you?
I'm fine.
Hello everyone, good afternoon. We would like to start our session now, and with Dr. Janki, Director of Diabetes Unit, Kim Hospital Research Center in India. Dr. Yajnik, MD, is currently a professor and the director of the Diabetes Unit in Kim Hospital and Research Center in Pune in India. His aim research interests include high susceptibility to diabetes in Indians, intra-uterine programming of diabetes, vitamin B12, and 1C metabolism. Thank you, Doctor, for your attending and presenting your lecture now. And you have 15 minutes from now to start your lecture.
My sincere thanks to Emirates Clinical Nutrition Society, the organizers, and Dr. Ghadeed Shamani for the introduction. I'm going to tell you a story of transgenerational transmission of diabetes. And it's not going to be really the genetic transmission, but the non-genetic epigenetic transmissions. I bring you compliments from the diabetes unit of the KM Hospital, which has a logo of mother and baby. And that is the concept of fetal programming as part of the message of developmental origins of health and disease. There is an international DOHAD society, of which I am a founder member and a current trustee, and an Indian Sneha society, of which I am the president. Our second logo includes this modern Ganesh, who is, who is now actually not traveling on the back of this mouse, which it used to do, but clicks the mice of the computer while he is working from home. And that's the rapid lifestyle changes that have happened. So a combined effect of intrauterine programming and a rapid transition combined to increase diversity across the world, and some parts of the world are more affected. My confessions I have written about 5 years ago. Those of you who are interested, please read them in European Journal of Clinical Nutrition. And what I said there mostly is that if you want to do something good, the universe conspires to help you. And as part of my research and philosophy of DOHAD, we actually agree with Søren Kierkegaard, who is a Danish philosopher, who told us life can only be understood backwards, but we need to learn and we must live forwards. So that's the message of DOHAD. Terminology-wise, diabesity is a combination of diabetes and adiposity. And by adiposity, we mean body fat percent. The commonly used term obesity is weight for height. There is no fat measurement there. And therefore, you cannot equate adiposity with obesity, though they may be strongly related. Intergenerational is between 2 generations, and transgenerational means more than 2 generations. And the current textbook dogma for diabesity is that the susceptibility is genetic. And today, after the human genome discovery and the Jiva studies, we know it's polygenic. But even if we look at all the studies done for diabetes and obesity, 10 to 15% can only be explained by the polygenic inheritance. For obesity, it was only 6% in a systematic review in 2021. So large percentage of it, 80–90%, comes from environment, and it's related usually in the textbook to age and lifestyle of the adults. Diet, physical inactivity, and stress, and like I said, modern Ganesh. These are usually considered to be representative of overnutrition in the world. What I'm going to try and convince you is that the usual address of eat less, walk more, or take drugs to prevent or treat diabetes might be all right in some parts of the world, but we might like to actually find a modifiable susceptibility factor, in which case we will do much better because we will probably do it much early in life and it will help us in more than one conditions. So last 35 years, my department has spent a lot of time doing number of studies. I'm showing only some of them here. And starting with studies in adults, the Belgian diabetes study, which we did in 1987, when we described the role of central obesity in 1987 as a risk factor for Indian diabetes, and described the so-called thin fat Indian phenotype, which I'll show you a little later. And then a series of studies in children, in pregnant women, then in adults for mechanisms, then various micronutrient studies, and finally, many intervention studies are actually part of our portfolio. We are also very interested in diabetes in pregnancy and have published since 2005. And we have actually much more exciting things coming in future. So one of the questions which has arisen over time is the modifiable susceptibility for diabetes originating in the mother's health? Because we know mothers are a stronger determinant of risk of diabetes in the child than fathers may be. And proof for this was actually available in a series of papers in the last quarter century of the last century. So when I was training as a doctor in Pune in 1976, there was this remarkable paper from the Dutch winter hunger study, which I am sure all of you know, that children born during the Dutch winter hunger, that's in the last 6 months of the Second World War, had either increased risk of obesity as army conscripts if they were born or if they were exposed to hunger during the first 2 trimesters of pregnancy. If they were exposed to hunger in the 3rd trimester, they were less likely to be obese compared to the background population. And this at once told us that nutrition in pregnancy in different windows can have a long-lasting effect on future health of the individual. Studies in the Pima Indians in the state of Arizona in the USA also showed quite interesting findings about gestational overnutrition as opposed to undernutrition during the family. So what they showed was if mother had diabetes during pregnancy, she was overfeeding the baby, and these babies were at higher risk of obesity as well as glucose intolerance in later life. And then came David Barker studies in 1980s and 90s, which showed an inverse association of birth weight with risk of diabetes. That time it was called syndrome X, now we call it metabolic syndrome, and other cardiovascular outcomes and other outcomes in the brain, etc. So together we can now say intrauterine malnutrition, either under or overnutrition, may be related to subsequent obesity and diabetes. And again, when I said it may not be genetic, I think I have to now convince you that it may be epigenetic. And I'm sure all of you know about epigenetics. These are the changes in the genomic structures other than the sequence of the bases. So it can be DNA methylation, it can be histone modifications, or it may be effect of certain miRNAs. All these change or influence the gene expression and therefore the phenotype despite inheriting the same sequence of bases. And the influences which can cause epigenetic changes are nutrition of the mother and a number of other environmental and social determinants, mother's metabolism like diabetes, so that an artist has drawn this very innovative picture of DNA as being actually coated by the food which you eat so that it can change the function of the genes. And this led to the concept of programming, which means that exposures during intrauterine life can have lifelong effects on structure and function of the developing organism. If they are adverse, then it restricts the plasticity of the growth and might predispose you to disease. There are, of course, like I showed you, windows of vulnerability, which may be the windows of opportunity. The most powerful window is pre and periconceptional, that is even before the woman knows she is pregnant. And we know about the famous 1000-day concept, which covers the pre and it doesn't really cover preconceptional, but it covers pregnancy and lactation. Puberty is another possibility. And interestingly, it may be reversible, and that's why we are so much interested. Another interesting fact is if there is an intrauterine exposure to adversity, the development dictates that the brain growth is preserved. And this is achieved by diverting blood flow to the pre-ductal structures, and therefore the post-ductal structures suffer. Post-ductal structures include liver, muscle, kidney, and pancreas, and you will be immediately reminded that these are the contributors to the non-communicable disease, including diabetes, hypertension, heart disease, etc. So that allows us to think about what we now call primordial prevention, which is even before the beginning. That means if you, even before you're conceived, preconceptional. And India is one place where a massive opportunity exists for such research because India is the capital of two prominent conditions at the same time. On one hand, it is a world capital of diabetes, at the same time as being a world capital of undernutrition in early life. So India produces largest number of low birth weight babies and a very large number of under 5 undernourished children. And therefore we need to think of life course nutritional history, and mother and baby pair then becomes very important. Another interesting thing about India is that this is multi-generational undernutrition, as evidenced by the change in height in the populations between 1830 to 1980, so 150 years. Yellow line is India, no gain in height at all. Europe, Netherlands gained 15 centimeters in height during 150 years. So that means there has been multi-generational undernutrition in India and other Southeast Asian countries. And this has resulted into a phenotype which I described. It's called Thin Fat Indian. And this is a dramatic picture of me 25 years ago with my friend John Yutkin from London, where we measured our body mass index, and to our great surprise, we realized we have identical BMI, 22.3. But when we measured our body fat by DEXA, John's body fat percent was 9% and my body fat percent was 21%. For same BMI, a multi-generationally undernourished Indian had more fat and less muscle. And we called it YY paradox, Yashnik-Yudkin paradox. So then we set out to study why Indian babies are so small and how a life course evolution of phenotype evolves. This is the famous Pune maternal nutrition study, which I set up in 1993 with help of Professor David Barker and Caroline Paul. And we studied women from before they were conceived during pregnancy, and we studied their nutrition, metabolism. We also studied their husbands. We studied fetal growth. We measured babies at birth, and then we measured them every 6 months for 18 years, and then every year. And then every 6 years, we study the child and both the parents for a range of cardiovascular risk factors with an impressive follow-up rate up to COVID, more than 95%. COVID put a halt for 2 to 3 years, and now we have picked up to follow them up between 25 to 30 years of age. We also set up a biobank, and therefore we are able to answer many questions in a biobank if we raise the questions after the study is examined, after that point is gone. And the mothers were on average 42 kg with a BMI of 18.1, and 50% of babies were small for gestational age with an average weight of 2.7 kg. Mothers were predominantly vegetarian. They ate less than 75% of recommended dietary allowance. Large part of it was carbohydrate. Lower intake of micronutrient-rich foods. Lot of physical activity. And very less gestational diabetes 30 years ago. A lot of B12 deficiency, but no folate deficiency in this population. I'm going to ask you an interesting question. Now, this many of you will know Christopher Robin and the 100-acre woods. In one of the summers, he invited all his friends for a spelling competition. So they were all welcome, and you can see what spelling they have done of welcome. So he asked them to spell adiposity. And Winnie the Pooh spelled it as adiposity, thinking it was a city in America. That's the fun part of it. Now I'm going to ask you if all the animals which are present in this gathering, which animal had the highest fat at birth? Was it Winnie the Pooh? Was it Piglet or Eeyore or anyone else? Any answers? I can't hear you, but let me tell you the answer. It was Christopher Robin. And this is a very important thing to understand, that humans have highest fat percentage amongst the mammals at birth. Piglet has only 2%, sea lion only 5%, baboon only 3.5%, humans 15%. So evolution has actually put in a lot of efforts to have a extra amount of fat for the human baby for its protective effects in the postnatal life. And we demonstrated by comparing babies born in Pune with babies born in Southampton that there were interesting and unexpected differences. The Indian babies were 2.7 kg, the English babies 3.5 kg, 800 grams lighter, the Indian babies. This zero line is an English baby, and these are the standard deviation scores. Indian babies were small in all measurements, but there was a hierarchy. Smallest measurement was abdominal circumference, and the subscapular skin fold, central skin fold, was almost similar to the English babies. If we did a pairwise analysis by birth weight, Indian babies actually had larger subscapular skin fold, higher insulin and leptin concentrations in the cord blood, lower adiponectin concentrations, and in 30 babies, we did whole body MRI. That showed us that though the abdominal circumference was the smallest component, actually it was hiding a lot of fat inside and surrounding the abdomen. So this is the thin fat Indian baby and tells you that the phenotype originates in intrauterine life. Therefore, preconceptional and pregnancy nutrition are very important. We then followed up these children, and at 6 years, we found an interaction between maternal B12 and red cell folate nutrition. You will remember 2 out of 3 mothers were B12 deficient. So they are very low B12 status population. And of these, those who were most deficient and those who at the same time had highest folate concentration, their babies were most insulin resistant, HOMA-IR, fasting glucose and insulin model. And they also had highest adiposity. So higher insulin resistance and higher adiposity are 2 major risk factors for future diabetes. And that is linked with an imbalance of 2 micronutrients in this very B12 deficient population. And this kind of nutritional imbalance has arisen in India because of multi-generational vegetarianism. Samrat Ashok started it 2500 years ago when he became Buddha's disciple, and Buddha taught him about ahimsa or non-killing. 3 major religions support it, and very interestingly we found higher education, higher income and better hygiene predispose you to B12 deficiency. Why? Because B12 in nature is made only by microbes. No other organism is able to synthesize it. On the other hand, folate is higher with higher food intake, better socioeconomic status, and Indian national programs supplement iron and folic acid to adolescent and pregnant women. And obstetricians use a lot of high-dose folic acid to prevent neural tube defects. So that creates an iatrogenic imbalance. What happened to these children at 18 years of age? They are still only 19 kg per meter square, but almost 30% of them had pre-diabetes, 40% in the males, 20% in the girls. They're still B12 deficient. Almost more than half are B12 deficient. So a lot of pre-diabetes at 18 years despite relatively thin body size. And when we could look at their characteristics, which we had studied over 30 years, we found those who were pre-diabetic had shorter birth length, smaller head circumference, and mothers were not overweight or obese. But despite not having gestational diabetes, they had higher glucose in the normal range. Father's glucose influenced daughter's pre-diabetes. And boys who were pre-diabetic had developed pubertal adiposity, that means higher body fat percent, though they had still low BMI, so they were thinner and fatter. So that's a remarkable combination of risk factors for pre-diabetes in this population, reminds us of the concept of double burden of malnutrition exposure. And when we looked at their own glucose at 6 and 12 years, we found that their fasting glucose at 6 years, if it was in the highest quartile or quintile, then it increased the risk of pre-diabetes by 3 times. At 12 years, similar situation increased it 6 times. So the things are seen right from early childhood, also early puberty, and therefore there is a scope to screen and do something. The classic teaching in textbook is pre-diabetes in the young is actually driven by insulin resistance. That was not at all true in our population. Their insulin resistance at 6 and 12 years was similar. HOMA beta, though tended to be a bit low, was still significantly not different. But if you plotted HOMA beta against HOMA S, what is called disposition index, those who had pre-diabetes at 18 years had a lower disposition index from childhood, early puberty, and also in the 18 years follow, suggesting to us that their beta cell function was actually compromised from early age. And we were then able to actually start looking at whether B12 might be responsible for some such things, at least in a small way. And what we find in our studies, in B12 intervention studies, we find that B12 supplementation was able to epigenetically modify, that is methylate the genes for common diabetes risk genes like FTO, TCF7, KCN, and a few more. And there was also an interesting methylation of the gene for miRNA 21, which has very interesting effects on the cellular function. In another study, we found in the cord blood of the babies whose mothers had received micronutrient treatment, their cell cycle was reset. Interestingly, that means their capacity for growth and differentiation and division was affected. So that's quite a remarkable finding. And in another study, we found that mother's adipose tissue secretes these extracellular vesicles, which we call exosomes. They contain miRNAs, and the miRNAs in the exosomes of the mothers of the adipose babies actually were driving various metabolic pathways which would influence adipogenesis in the baby. In other words, there is a crosstalk between maternal adipose tissue miRNAs and the development of the fetal adipose tissue. Quite a remarkable finding. This paper is waiting to be published in an international journal of obesity. Then we have done a B12 trials in the adolescents in our cohort. And I think this is world's first preconceptional micronutrient intervention in adolescents to actually influence the health of their babies. And it took us 8.5 years of follow-up in our cohort to actually see the effects. We still haven't measured their glucose insulin, but their neurocognitive function has improved if the mothers were given B12, cognitive as well as language.
Yeah, doctor,
Now,
thank you.
one more interesting. Yeah. Can I just continue 1 minute?
Okay, yeah.
Yeah, sorry. One more interesting thing is that if the mother is pregnant with a female child, then the interesting fact is that this female child in the mother's womb has all the 1 million ova it will always have in its life, or it will ever have in its life, from 11 to 20 weeks of gestation. So if you are actually improving nutrition of a mother who is pregnant with a female child, you have an opportunity to influence health of 3 generations. Very important, And I think this I'll drop. And I'll say we have done a film to educate the public about the importance of maternal nutrition in pregnancy. You're most welcome to see it on the KEM Hospital website. It's a beautiful film. And I've done another film to improve the public education of nutrition in pregnancy. I'm going to thank all my colleagues, all the participants in our studies, and the Indian SLOHAD group, that is SNEHA, which is the first meeting in 1993, Professor David Parker there, and I was quite young, and the village staff who has made our studies possible. And we have been funded by the Wellcome Trust, MRC, BBSRC, all the Indian funding agencies, and we are very grateful to them. Thank you for patient listening, and I hope I have convinced you mother's nutrition is an important determinant of fetal health. Thank you.
Okay, thank you, Dr. Yashmik. Very interesting to talk about some, the role of the genetic background of the people and the roles of that and related to diabetes. Okay, so we'll start with Dr. Rima Sultan. Welcome, Dr. Rima Sultan. Ali is a clinical dietitian with a rounded experience from hospitals, specialty clinics, flight catering since 2003. Dr. Rima will talk about immunity in cystic fibrosis.
Okay, my topic for today, good afternoon, good evening to everyone. My topic for today is medical nutrition therapy and cystic fibrosis. The learning objectives, I'll run through this very quickly. Learning objectives is to understand what is cystic fibrosis, what is our role as a dietitian in the management, please make sure we understand management. Cystic fibrosis has no treatment. It is all about our role as helping the patient to manage. Exercise and cystic fibrosis, nutritional assessment and growth, which is very important. Calculating the energy, protein, fat needs of the patient, helping them what is the good practice principles, feeding route, PERT, and finally the other comorbidities which are involved along with cystic fibrosis. What is cystic fibrosis? Now, instead of going through the slides, I'll quickly speak and explain what is cystic fibrosis. Cystic fibrosis is basically whatever membranes that we have in our body get clogged with the mucus, which we normally all of us have. This mucus is normally very thin and it allows the absorption of nutrients in and out. It helps or makes easy for the patient to breathe. Whereas in case of cystic fibrosis, this mucus thickens up, it becomes jelly-like, it narrows all the passages. So in the gastric, you will see that it prevents the absorption of vital, important vitamins, minerals, fat-soluble vitamins, a lot of electrolytes. If you look at it in the lung, it makes breathing difficult. So the complete uptake of oxygen by the patient is affected. It usually develops in the early age, detected by the age of 2 years. There are patients detected later after an episode of an infection, or they have learned how to manage the issue. So they get detected later in their life by the age of 18 years. Initially, this condition had a very low life expectancy. By the age of 9 to 10 years, the children, because there was no proper management, there was nothing called as a proper interdisciplinary team. I can see a lot of faces here as dietitians. We understand today that the doctors understand and accept the importance of dietitian being in the interdisciplinary team. So we work along with the doctors. Where they have difficulties, they consult with us. When we have medical or understanding a condition difficulty, we discuss with them and they help us break down the condition so we know where we take the management from that phase. Now, now the life expectancy has increased for 31 to 35 years. Again, if proper management is there, there are certain patients who live even beyond that. Keeping this point in mind that the life expectancy is from 31 to 35, 40 years, just understand if I were to know from tomorrow, I love Tobler. If I were to know the company for Tobler was shutting down and there is no more Tobler available in the market, just the chocolate Tobler, it will make me anxious. It will make me want to stock up. It will want me to look for an alternative. Imagine this is their life. They know that they may not live beyond the age of 40 years. They're already developing the symptoms. There are exacerbations. They're having a lot of hospital admissions. So the anxiety and the depression that they go through. So your role as a dietitian is just not medical nutrition therapy. You're also actually a counselor to them. Be patient with them. Many a times I have seen this in my practice. The patient is going to open up to you more than to their doctor. Like when I worked with one of the endocrinologists, this was a very, very nice endocrinologist, I should say. I was blessed I worked under her. She would not write the insulin at the first visit. She would send the patient back. You do the carbohydrate counseling. You wait with this patient for about 6 weeks. No effect, then you will go ahead. And she will give the insulin. But at this stage, the patient will come back to you. I'm not going to take the insulin. But in front of the doctor, it is like, I'll do it 3 times a day, pre-meal. How many units? How do I calculate? So it's you who is also working as a second-hand psychological counselor with the patient. Please be patient with these patients, right? Okay. Like I said, it is a recessive autosomal hereditary disease. So you can't prevent it. It comes genetically. You can help manage it. Normally, if 2 parents are suffering from cystic fibrosis, the child is probably going to have it. So proper genetic testing has to be done. If 1 parent has it, the child has a higher chance. It affects most of the organs in the body because all the passages get stuck up with this sticky mucus. So it becomes difficult to breathe. It becomes difficult for absorption. It becomes difficult for these hormones and enzymes to be released in the body. So it becomes a multi-organ issue. It is seen in young adults. It is seen in children, young children. Like I said, diagnosed by the age of 2 years. What are the diagnostic tests? The diagnostic tests is the sweat test, genetic testing, X-rays, chest X-rays, sinus X-rays, lung function tests are done, and the fecal fat test. Because of it affecting the pancreas, the fat will not be broken down. The bile ducts are blocked. Fat will not be broken down. There is no absorption. So as a dietitian, we know we will have a problem with the absorption of, can anyone tell me here just to wake you all up? What will not get absorbed if there is a problem with our bile duct? Which vitamins, which minerals? Anyone? Yes, they are very vital, and we need to make sure that we are giving them an alternate source, or we are giving them something which will help this fat to break down, so help in the absorption. Treatment, like I said, there are medical treatments to it. Gene therapy is done. Antibiotics and aerosol sprays are given. Pancreatic enzyme replace therapy becomes important for the absorption and taking care that all the vitamins and minerals are taken in. The flutter is done. Now, all this doesn't concern us. But the last one, nutritional support. We are there, or we should be involved in helping these patients to manage their condition and their symptoms. There are 1400 known mutations of this. So each patient is individualized, each treatment is individualized. Some may have some organ affected, some may have a multi-organ affected. Now, this makes simplified what all I have explained. That is a normal artery we see. You see, it has a very thin mucus, which is natural, and it is there to prevent the bacteria or the viruses to adhere into our passage. The other picture is the cystic fibrosis airway. It is covered with a thick mucus. Now, there is a bacterial infection there. So you see, the nutrients can't pass through, proper oxygen can't pass through. So these patients will also have condition like anemia. And all the organs that it affects are, it will affect the sinuses, it will affect the lungs, it will affect the skin, the liver, the pancreas, the intestine, and the reproductive organs as well. Our role is here, we need to take care in the early childhood, proper measurement of the circumference of the head, the height, the weight has to be done. So we know that the child is properly growing and maintaining an appropriate weight. In the adult cystic fibrosis, we need to make sure that the patient is getting enough amount of his calories, proteins, fats, stuff like this. There is no point in putting the patient on a very calorie restricted diet. Here we have to remember that we as dietitians don't only have to think of MNT, you also have to think of the condition as a practical aspect. You tell the patient, don't eat this, don't eat this, don't eat this. He already isn't eating anything. That's all that he's eating. And now you stop him from eating that. So what are you going to have? You'll have severe malnutrition in this case. So you have to carefully plan his diet. A proper recall is required. A proper diet plan, individualized tailor-made diet plan is required. We need to take care to boost their calorie intake, because as they progress and it becomes difficult for them to uptake oxygen, their food intake will go down. So we need to give them small, high protein, high energy snacks. Helping the persons and checking and helping the person, making sure that the enzymes are working properly, making sure vitamin levels are normal, and addressing any other nutritional needs. Like I said, we do the job as a psychologist as well as a dietitian. So we patient and take up from them what they want to express, and you may be able to pass it through the higher team in your interdisciplinary plan. Exercise and cystic fibrosis, these patients also, I have seen asthma patients, pneumonia patients. Since our hospital was dealing with the COVID patients, we had seen that once these patients got any one of these breathing difficulties, they would stop all form of exercise. They just wanted to sit on their bed and continue that. No exercise, more loss of lean muscle mass, loss of flexibility, loss of oxygenation. So we have to encourage them to exercise. You know, it will help in increasing the appetite. It will help in achieving the optimal body weight in case the patient is overweight. So you don't cut down a lot on the calories. You do it like a 250 from the food and a 250 from the exercise burning. It helps in increasing the muscle strength for the patient, bone health, pain management, and relieve stress. Chest physiotherapy is a must. These patients should be forwarded to a chest physiotherapist. Sometimes the part of physiotherapy gets missed out, but this has to be considered. Exercise may not be in a continuous phase of 30 minutes. You need to break it down into smaller units, like let's say 10 minutes, 10 minutes, 10 minutes, or even smaller at 5, 5, 5 as they feel comfortable. The main aim of exercise here at times is not just fat loss. It is oxygenation and flexibility and helping to retain the muscle. We need to take care in these patients when you ask them to exercise regarding their hydration, because they are so full of this thick mucus that they don't feel thirsty and they feel blocked. So their hydration goes down. Salt replacement has to be taken care, like we saw earlier in the diagnostic test. We need to do a skin salt test because they lose a lot of salt in their sweating. We need to, for example, the exercise program has to be worked along with the patient, the physiotherapist, and someone who will help or monitor these patients. I'll quickly run through this. The exercise suggested for these patients is between about 60 minutes every consecutive day. This 60 minutes broken down in the entire day, not at one time. So it's 1 day of exercise and 1 day of a break, 1 day of exercise and 1 day of a break. For the adolescents, it is 150 minutes, adolescents and adults, it's 150 minutes, again on every consecutive day, broken down as per their convenience, how they feel well about it. Don't push them a lot and tell themselves not to become Superman, Superwoman. I can, I will, and they will do it one day and then they will. That should not be done. Please plan it for them. Teach them how they do it so that they can maintain it and be regular with the exercise. Nutritional assessment and growth. For small children, the head circumference, the height, the weight, and the BMI for adolescent and adults. Now, how frequent for the young children who are in the hospital, babies 0 to 2 years, it has to be done twice a week. That is the head circumference, the weight, and the height, because this is their rapid growth period. You'll be able to plot them and make sure that they're growing properly. For the children and adolescents, it's on their every clinic visit. Now, I'll tell you about the clinic visit. It's every clinic visit. In the adults also, it's at every clinic visits. In the adolescent, children and adolescent, that is from 2 to 18 years of age, sometimes like we used to see in pure diabetic kids, type 1, the parents are crying, the child is ignorant about his own condition. So the parents are crying, and for them to accept and apply this knowledge down for their child, it takes time. It takes about 2 to 3 visits in the initial phase for the mother to accept it. There is a phase of denial in the initial phase. Once they have accepted it, a monthly visit is appropriate. Once the mother or the parent caring for the child has learned how to take or handle the situation, once in every 3 months, the visit is comfortable. For the adults greater than 18 years is once in 6 months, and further can be once a year. Growth is delayed. If you've done proper charting and plotting, you will know how the child has got his weight, how catch-up growth was done, and how the whole situation is going. So it's very necessary that a proper assessment is done for the child. In assessment for body composition, it is very important. We at the clinics normally have these BCA machines which tell us how much fat-free mass, how much fat mass, how much muscle mass. It helps us in any patient suffering from a breathing difficulty, not just cystic fibrosis or any medical condition. So you know whether the patient is progressing to benefit, is stagnant, or is going down. A BMI of 22 for the females and 23 for the males is considered as sufficient, but do not start working on the patient's weight when they are at 22. So when you're getting a BMI of 23 in the females, 23, 24 in the females is the right time to start working on their diet and making sure that they're consuming the entire amount. In case of males, the correct BMI is 23, which would be considered normal. But by the BMI of 24, 25, start working and making sure that the patient is consuming his requirements and is no more further losing weight. What are our goals? One is to control maldigestion, malabsorption, to make sure that the BMI is maintained, to make sure that the other functions of the body are going well, and there are no nutrient deficiencies with the patient. Dietetic supplementation, as we all know, supplements are not the first thing that we run to, but we have to remember this, that in case, first is oral intake, oral intake, oral intake. If the patient is not able to meet his needs through an oral intake, then of course supplement becomes important. Now you start with oral supplementation. In the market, there are a lot of high protein, high energy supplements available. Nowadays, I also see there are these ready custards or these yogurts available, which makes it very easy. Medical nutritional products available. Even if one wants to supplement himself with 1 or 2 of these nutritional supplements, there are things like Greek yogurt, fruit flavored yogurts, they can be added into the diet. Diet, that is the normal diet, should be a cardioprotective diet because they tend to have high cholesterol levels. So you make sure that you're giving them a cardioprotective diet. All these ketogenic diets, very high protein diets, not required. In case ONS supplements are started, ONS supplements again can help to prevent weight loss. First choice would be food first, then comes the nutritional supplement. The supplements can be placed in the snack breaks. If you start with ONS and yet you're not able to meet the patient's requirements, then you go in for the nasogastric tube. Of course, the first choice is the nasogastric tube. Again, if there are complications, then you go further ahead, you go for the gastrostomach feeding methods. In the nasogastric feeding method, if it's a long term, then you have to go for a PEG tube. These feeds are normally given as continuous feeds or overnight infusions or bolus feeds. Overnight infusions are preferred for young adults so that it gives them the freedom during the day to move around, and the community doesn't look at them as if they are sick, because this infusion is going on in the night. In the daytime, they will consume whatever little they are able to consume. First choice in feeds would be polymeric, simple standard formulas. If they are not able to meet, like we will see in my last part, they have comorbidities, then you have to plan their formulas based on specific feeds. For example, if the patient has a pancreatic or a hepatic insufficiency, then the feed has to be a hepatic supporting one. So first choice will be polymeric feed, then comes semi-elemental, elemental with MCTs to help them to absorb the fat so that they can maintain their weight. It becomes a source of energy. Again, MCT oil need not be commercial just from the pharmacy. It can be incorporated from the diet, like coconut being one of them. So nowadays we see on these social media sites, and sometimes it's a good way to put it across. They are taking a spoon of coconut oil and blending it with the tea and having it, blending it with the coconut, making some cookies out of it. So these are some alternate ways of incorporating MCTs into your diet. Pancreatic enzymes need to be given. Again, as a dietitian, is not our role to put this. This is the doctor who takes care of it. But again, you can always suggest or advise your doctor that this needs to be done because there is malabsorption of multivitamins. Glucose tolerance has to be taken care because one of the comorbidities of cystic fibrosis is cystic fibrosis related diabetes. Now, this is the hormone replacement, the enzyme replacement. Enzyme replacement is important even if the patient is taking ONS or is taking enteral or is taking parenteral. We need to consider because the fat will not be absorbed. Normally preferred to give the oral tablet because otherwise the tablet will block the tube and will cause complications. Vitamins and minerals, most important vitamins are the, like I mentioned, fat soluble vitamins are important. It is more important for patients who suffer from pancreatic insufficiency. Factors which contribute to fat soluble problems are, like we see, pancreatic insufficiency, bile salt deficiency, poor dietary intake. These can be the causative factors. Short gut syndrome, previous bowel resection. So if a certain amount of bowel has been resected, the precursors are not present, so the patient will not absorb the vitamins and minerals. So it is important as a dietitian, sometimes when we look at the patient file, we just say he has undergone a previous gastric surgery. That is a very superficial way to look at your patient. You need to go back to your doctor. Sometimes that I did that initially with my surgeons. They go, what do you have to do about it? No, I have to do about it because in the entire gastric tract, there are different sections which are absorbing different vitamin minerals. There are different sections having different precursors. So if one part has been resected, I need to intervene. I need to take care that I'm giving it externally to the patient. Okay. Also short gut syndrome or previous bowel resection that I mentioned. Cystic fibrosis related liver disease. So that's when the insulin issues were. And chronic antibiotic use, as we know, when we use a lot of antibiotic, our gut microflora is all disturbed. So the absorption will get affected. Minerals of importance, sodium. Due to a lot of sweating, diarrhea, vomiting, stoma output, the sodium levels go down. So we need to take care that they're taking the sufficient amount of sodium. Now, stopping on this at sodium, this is my common observance at the hospital. A patient in the ICU has a low sodium level, sodium running in 125, 130. Doctor puts an order, 6 to 7 grams of NaCl from the kitchen. Is it really going to be absorbed? No, they need to look at it to add in either, like we used to say for our doctors during the COVID phase, why don't you give him saline, might help in absorption of sodium. I cannot dissolve salt in water and give him to drink. So we as dietitians need to look at our dietary orders very carefully. Calcium important, again, because of cystic fibrosis, the bones are very osteoporotic and osteopenic. So we need to see that we're giving them correct amount of calcium. Overload of calcium cannot be given because they suffer from renal problems, so renal stones may develop. It should be given in the right form. Magnesium important. Hypomagnesemia appears to be mainly due to the nephrotoxic effects of the renal tubular damage. So we need to consider the amount of magnesium given to the patient. Iron deficiency may occur due to bleeding, due to gastric insufficiency. So again, iron anemia needs to be monitored. Also, there is less oxygenation of the blood, so the heme and the globin part of it will not form properly. Now, the comorbidities that I mentioned, bone health, we need to consider, we need to keep in mind. So cystic fibrosis related diabetes, this is my main focus now. Liver disease, renal disease, gastroesophageal, and distal intestinal obstruction syndrome. Now, as dietitians, when you see cystic fibrosis, go deeper, dig into it, see what other comorbidity is involved. Then your diet plan or your MNT has to be put in hand. So if the patient doesn't have anything to do with another comorbidity and is just suffering from diabetes, work on diabetes and cystic fibrosis. If the patient has a renal insufficiency or a renal problem progressing to the end stage renal disease, now the protein needs to be controlled. It is cystic fibrosis related diabetes is caused by the pancreatic damage. The thick mucus will clog the tubes in the pancreas, making it hard for the pancreas to function. The hormones and enzymes, that is insulin, will not be secreted, so we need to take care of that. Symptoms of cystic fibrosis diabetes, same like that of diabetes. Diabetic diet with cystic fibrosis, same diabetic diet, so proper carbohydrate counting has to be done. Do not go less than 130 grams of carbohydrate. Hypoglycemias are not appreciated. Protein requirement in just a diabetic can go from 1 to 1.52 grams depending upon the need. In case it's a renal case, then you go from 1 to 1.5, not more than that. In case you have a very obese patient and you want him to lose weight, for the females, go for a calorie restriction and put them in the range of 1200 to 1500 calories. For the male, between 1500 to 1800 calories. Of course, taking in consideration, are they even consuming that or no? Fat can be between 35 to 40% of their calorie calculation. But again, see which kind of fat you're giving. Make sure that you're not giving them a lot of saturated or trans fats. Liver disease, like I said, these are all the comorbidities. Now, this is the important part. Keep in mind the patient has psychosocial issues, has anxiety, has depression because of the fear of his next admission to the hospital, because of the fear of his lifespan being shortened, because of the fear of I will go on my feet, I may not come back. So there is a lot of anxiety going on. Please be very calm, polite, patient with your patient to understand what he really needs from you. Smoking cessation has to be done. We have seen a case with had cystic fibrosis but used to smoke. We know what are the detrimental effects of smoking. That's it. Take home message is be patient with your patient, be a human, stand in his feet, understand what he's going through. Supplements are not bad. When you can't meet it through the oral diet, supplementation has to be done. Supplementation goes step by step. Of course, first encourage oral nutrition. Eating it, if no, drinking the solution, if no, then goes to enteral nutrition, if no, even if it is parenteral, it is not bad. It's the need of the patient and you have to give it to him. Thank you.
Thank you very much, Dr. Reem, for that wonderful presentation. Our next speaker for this session is Dr. Suhail Ashraf, consultant endocrinologist at Mubadala Health, Dubai. With more than 11 years of experience in his field, he has graduated from the Armed Forces Medical College, Pune in India, and holds a dual certificate of completion of training in endocrinology and diabetes and internal medicine, who is also fellow of the Royal Colleges of Physicians and Surgeons of Glasgow, Edinburgh, and London as well. Has a master's in diabetes from Queen Margaret University in Edinburgh, UK, as well as a PhD from Edinburgh, UK, and an MBA in healthcare management from the United Kingdom. Thank you, Dr. Ashraf.
Ladies and gentlemen, thank you very much, Alia, for the kind invite and the kind introduction. This is my first time here, and I'm delighted to be presenting about diabetes and endocrinology in adults. Now, it's a very big topic to cover in 20 minutes. I hope you will agree on that. So I've just cut down on the diabetes. I've taken the liberty to present only the type 1 and type 2 diabetes. While growing up, we all have memories of what our mom and father used to say, one-liners, catchphrases, or pearls of wisdom. And one of my mom's favorite one-liners was, "We are what we eat." And every time, we'd ask our mom to take us to the McDonald's or KFC, she'll remind us, we are what we eat, to enforce healthy habits. And it is only fitting that I remember that today as I stand here to speak about two pandemics of our time, diabetes and obesity, in a nutrition conference. It's a Sunday afternoon, and I understand that, so I'm not going to be very text heavy on my slides. They're fairly light. I'll try to run through them. If there's any burning questions anyone has, please catch me after the presentation. So this is my outline. I'll be talking about type 1 diabetes, mainly incidents, a couple of slides, recent updates. And when you talk about type 1 diabetes, you have to talk about technology in type 1 diabetes, type 2 incidents, recent management, and guideline update. Right, so shall we get started? First one is the incidence of diabetes. You'd all agree that type 2 is exploding, but type 1 is also increasing across the globe. As you can see, we don't have enough data across Asia, Africa, and most of Central America, and that's a tragedy, because wherever the data is available, the numbers are increasing big time. But it still gets more depressing because of this. All the young type 1s that we're diagnosing, we're realizing that their BMI is on the heavier side. So this is data from the 4 registries. Search and Type 1 Diabetes Exchange is from the US, SWEET is from Europe, and DPV is from Austria and Germany. And not surprisingly, about 30% of the type 1 diabetic patients are either overweight or obese, which is a bit of a tragedy, really, because this is a group which we always felt were young, were fairly, well nourished, and we would never really worry about obesity in this age group. This is all treatment options. You would have seen this slide many times. I've taken this from ADA standards, diabetes care. The slide hasn't really come out too well. Apologize for that, but I'll run through you the slide. On the top, you've got the injected insulin regime, the MDIs, with long-acting analogs or rapid-acting analogs, or these days, as we call them, ultra-rapid-acting analogs. So different types of insulin in the first 5 groups, and towards the bottom end of your slide, you've got the continuous insulin infusion regimes, CSII, as we talk about, which are insulin pumps. And these have taken over the world of type 1 diabetes, and rightly so. So we have the hybrid closed loop technology at the moment, which is probably the best technology we have. Below that, we have the insulin pumps with threshold predictive low glucose suspend, and right at the bottom, we have insulin pumps without automation. What these do is they give you a lot of flexibility about how to play around with your insulin and also your sugars. Plus, at the same time, increase the quality of your life. At the same time, also gives you hyperprevention. I'm not sure if you are aware about a new drug that has hit the market, teplizumab. So a lot of monoclonal antibodies have been working their way through in research in the world of type 1 diabetes. Unfortunately, none of them have had shown promise apart from this single medication. FDA approved this in November 2022. We as endocrinologists had our reservations because one, all it did was delay the onset of type 1 diabetes by about 2 years. Not very significant, but more importantly, there's only one randomized controlled trial about this with a sample size of roughly about 76 patients. And 3, more importantly, it's cost a lot, $200,000, 14-day treatment. And as you can imagine, this is not a drug which will be taken up by the insurance providers. Nevertheless, it's a start. I'll move on to technology in type 1 diabetes, which is my favorite topic. Back in the UK, I was a clinical lead for technology. So I've seen the world of type 1 management before technology hit it, and I've seen the world after technology hit it. And I can tell you hands down, technology has made a big difference in this age group. So If you talk about technology, you talk about three things. You talk about pumps or insulin delivery. You talk about measuring of glucose. And at the same time, when you put all these together, you talk about how you interpret the data, which is the digital healthcare. I'll talk about the insulin pumps first. Different pumps have been around for almost about 2 decades now, but this is the one that has really been a game changer. The reason being, this is a complete hybrid closed loop. And when I talk about that, it's a pump which has an interface on its mobile. And more importantly, it speaks with a sensor, at the same time decreases glucose before it goes low, and then takes care of your basal as well. So that's the beauty about this pump. Now this hit UAE about a year ago, I think. This hit US in 2018. So we have enough data now, about 4 to 5 years of data, and hands down, it has improved patients' quality of life, decreased hyperglycemia, at the same time, decreased the HbA1c. This is other types of pumps. These are patch pumps, so you don't have a wire attached to your body. A lot of young adults don't like wires attached to their body because of the body images. So these pumps are quite popular with them. All you have to do is just patch it up in your arm or in your belly, and that's it, you're good to go. Omnipod by Insulet has been around for quite some time now, and they're about to release Omnipod 5 in the UAE in the next few months. This is going to be talking to the glucose measurement device, thereby creating a hybrid closed loop. On the top, you have the EO Flow pump, which has just been introduced across the globe. They have come into the UAE market. It's a Korean company, very similar to Omnipod. So you have two options to go with. This is Camp APS. Very likely this is going to come into UAE in the next future. The reason why this pump became so popular was that everything was on the phone. It had an app. It was the first device where it was all app-based. So all you had was a pump, you had insulin in it, and all the remote control was on the mobile. And it was very, very popular because you'd go out to a restaurant, you want to inject some insulin, you don't have to take out your pump or fiddle around with something else. All you do is take out your iPhone, quickly enter some glucose levels and push press, and that's it, the insulin gets delivered. Nobody knows what you've done. Everybody would think that you're trying to text your friend. So that's why this became popular. I'm hopeful this will be hitting the UAE market soon. This is from the Boston Steve Russell's group, iLet Bionic Pancreatic System. The reason why this is catching up is that it has glucagon in it as well. So we are now aware that in order to prevent hypos, you do need a trickle of glucagon, and this is what these guys have done. Glucagon is a very labile molecule. So in order to make it long-acting, they had to insert lots of chemicals into it, which is called dasiglucagon, and that's why this has taken its time. Just in EDEC a couple of months ago, Steve was here presenting the data, and it looked very promising. But I have to remind you that a piece of kit is only as good as the user. If the user knows what to do with it, he can fly. But if the user doesn't know what to do with it, that's it, he's stuck. So this is a reminder about that. This was a REPOSE trial back in Newcastle, where we were one of the centers who participated in this trial. So what we did was, I'm sure you know, as dietitians, you'd know DAPHNE, which is dose adjustment for normal eating, which is one of the standard programs and structural education programs in the world of type 1 diabetes. So we had intensified DAPHNE education to some type 1 diabetics, and we branched them out into two groups, MDIs and CSIs. And what we did was we followed their HbA1cs over a course of 24 months. And this is what we got. The lines don't separate too much. The p-values were not significant, telling you that the MDI was not lower than the CSI group. So basically, you might have a pump, you might have insulin pumps, but as long as you know what you're doing, you'll still be able to crack the code. Moving on to the glucose monitoring bit, not everybody's on insulin pumps because they're quite costly. They cost roughly about 30,000 dirhams a year, but these devices are quite cheap. So they have become quite popular. You can measure the insulin at any time. You can measure your blood glucose anytime in your day. Interaction with pumps. So these are sensors which interact with pumps only. Then you have standalone systems like Dexcom, which all they do is measure the glucose and give it to you. And then you have some which interact with phone and watches. Libre, everybody's aware about Libre. It's probably the most popular glucose measuring device. It has revolutionized the way we manage diabetes because it just doesn't give you a glucose reading in time. It gives you arrows as to tell you where you're heading and where you're going to, so that you're more confident in your life. Ever since sensors was something that we used around 2015, 2016, these were implantable devices. So they would go subcutaneously under your arm, and then you'd have a sensor on the top, and you could measure your glucose for 180 days, and then you'd remove it. But the tragedy was that the transmission was lost in about 30, 40 days. So we had to abandon that. And ever since, it's out of the market now. The beauty about diabetes is everybody seems to catch up on the technology. So it's not just the pumps or the glucose measurements. You also have insulin pens, which can now document data. So these are the smart pens. Novo's come up with it. Medtronic's coming up with it as well. So you just need a transmitter. You insert the pen on the transmitter. You get all the readings about when you injected, and if you've married them up with the glucose readings, it'll show up the glucose readings as well. So that's a bit about type 1 diabetes. Somebody have talked about how the incidence of diabetes is going up. Obesity in type 1 diabetes is going up as well. I've talked about technology, which is only a boon in management of type 1 diabetes. Move on to type 2. Talk about the incidence talk about the incidence. This is everybody's bread and butter. Diabetes is type 2 diabetes is here and there. You look around, you don't have to see far, unfortunately. And if you look at the figures, Middle East or MENA countries seem to be leading the race, unfortunately. And that is not where the story ends. It gets more depressing because pre-diabetes is floating around big time. And a lot of healthcare companies and governments are beginning to wake up to the fact that pre-diabetes is something that you do need to deal with. It's not that you can just close your eyes and manage the diabetes bit. So I'm very glad to let you know that there are guidelines around this as well at the moment. Moving on to recent updates and guidelines update. What has happened over the last 10, 12 years, and the dietitians have been at the center of this, is that we have changed the way we look at diabetes. Early in the past, we thought this was something that, a lifestyle disease, but we never really figured out until 2011, when Roy Taylor in Newcastle, my previous colleague, went on to do a study called the DIRECT trial. That's coming up on the next slide. What he did was he gave selected group of patients 800 calories, so very low calorie diet. I'm sure you've read about this, and found out that if you can actually reverse the amount of fat in your liver, you can affect the fat in your pancreas as well. And if you lose 3% of your pancreatic fat mass, you can actually reverse your diabetes. That translates to roughly about 10 to 15 kgs. So type 2 diabetes is a reversible accumulation of more fat than a beta cell can handle, and that's at the bottom of it. So this is the DIRECT trial. Just in March in EDEC, he was here presenting about the 10-year follow-up study, and the data was very encouraging. Back in 2011, 86% of the patients who lost 10 to 15 kg weight loss went into diabetes reversal. The big question at that time was, without any medication, can they just maintain that weight only by diet and exercise? And he showed that 64% of the 86% were actually able to do that with some motivation and follow-ups. And the beauty about this part of type 2 diabetes is everybody's beginning to wake up on this. You've got medications to help you lose weight, but at the end of the day, they are medications. We don't have long-term safety data around them. Why not just hit your diet and get the solution? There was a consensus statement that came out in 2022 about remission of diabetes. I would highly recommend for you to have a read on this. It's quite interesting. So the twin cycle hypothesis, which Roy Taylor presented, was very simple. He said, as long as Okay, as long as you have you have positive calorie balance, you'll have more fat in your liver, and then you'll have more fat in your pancreas. And if you can reverse this, that's it. It's as simple as that. But this is really a work in progress because, 10 years data we have, 64% of the patients were able to reverse the diabetes. How about the 40% of the patients who were not able to manage? Because you can imagine we're surrounded by food, we have a sedentary lifestyle, and it's very, very difficult to maintain your weight. Will this lead to long-term remission? We don't know. We just have 10 years data. Like bariatric surgery, we have about 30, 35 years of data, and we can safely say that, with bariatric surgery, you can have diabetes reversal. We can't say that with low-calorie diet. And there's also a fact about slim type 2s. How does that work out? They don't have enough fat to lose. And how can we reverse the diabetes in that? Last bit of the slides. So the GLP-1 analogs, I can't talk about weight diabetes without mentioning GLP-1 analogs. They're the fashionable drugs on the market, thanks to all the celebrities who've been tweeting about them. The beauty about these drugs are they affect different organs. So diabetes doesn't just affect your pancreas, it affects so many other organs of your body. And these drugs act on these organs as well. I just want to share some data about sustained trials, semaglutide, Ozempic, which is. So this is Ozempic 0.5 and 1 milligram doses. And as you can see, the dark blue bar goes right at the bottom. The good bit about pharma companies these days are they are pitching like for like. So I draw your attention to the bar right in the middle, which goes down to the bottom, 1.8. Sustain 7, which was against dulaglutide. Dulaglutide is another GLP-1 analog, and they had the courage to pit a like molecule versus a like molecule, which never used to happen about 5 years ago. And Ozempic is much more superior than dulaglutide. It is actually superior to any of the other molecule, SGLT2s, metformin, and other medications included. This is the weight aspect of it. And you could lose about 15% of your weight with the highest dose possible, 1 milligram that is. These were all heavy people. The average BMI was about 27, 28. And the trial extended for about 50 weeks. So it's quite over a period of 1 year. If you lose 15% of your weight, great. Move on to, right, this is the bit that I want to emphasize. So these are not just weight reducing medication, they also protect your heart and your kidney. And the 3-point MACE has been very, very favorable. Last bit, SURPASS trial, which is basically about tirzepatide, which is the new kid on the block, released only in USA and UAE. So we are the only 2 countries which have it. I just wanted to highlight this bit. You have the GIP and the GLP analog combination. What the GIP does is decreases the nausea, which the GLP increases. So it matches up, and hence you can tolerate this medication better. It also does another thing. It actually increases your glucagon, whereas the GLP-1 decreases the glucagon. So a combination of the 2 seems to help very much. And these are the trials. I've lifted them straight from Lilly's website. SURPASS trials 1, 2, 3, and 5. If you see, what surprised me was the HbA1c 5.7. It's not 6.5. So this is diabetes reversal that we're talking about. And 62% of the patients can actually reverse their diabetes on this medication. The big question you will ask, and which is on your mind, I'm sure, is what will happen when you stop the medication. We don't know the answer yet. And weight reduction, 22% weight loss. That's fairly significant. We get about 30, 35% weight loss with bariatric surgery. So we're almost getting there. And my prediction is the way we're moving forward, bariatric surgery probably is not going to be very popular moving forward. I hope there are no bariatric surgeons in the hall. Right, so the last slide is about tolerability. As I mentioned, they're very well tolerated medications mostly. The last bit is about the ADA guidelines. Because we have so much evidence now, this is a fast moving field. Lots of guidelines have been updated. Now, this is a very busy slide. I highly recommend that if you're looking after type 2 diabetics, know this slide well, and the one after this, because it's important. You need to this gives you a perspective about how to treat the patient, you see. In the past, we've all been glucocentric, looking only at the glucose levels, and that was it. But this prompts you to look at the cardiovascular risk, the heart failure, the kidney, the weight, as well as the cost effects and hypoglycemia, which is. And this is the, I was talking about the cardiovascular risk factors. So SGLT2 inhibitors, which I haven't spoken about today, but the GLP-1 analogs and the GLP-1 analogs sit right at the top when you want to lose weight and when you want to protect the heart and the kidney. That's my last slide. Thank you so much for your time.
Thank you, Dr. Suhail, for interesting lectures. Now, just we have maybe 2 minutes question and answer for Dr. Suhail and Dr. Rima. Can you allow me to ask Dr. Suhail first question? Dr. Suhail, now we are talking about the technology and its role about control the glucose levels. Do you think in the near future we can use the artificial intelligence?
Thank you very much. Very interesting question. I guess the field of artificial intelligence or AI is ever expanding, and we don't know what it can do. It's a bit scary what it can do, whatever we know about. And I won't be surprised if it comes into the healthcare sector and looks into the glucose aspect. So when we were in the ATTD conference back in 2020, February in Madrid, just before COVID hit Europe, one of the companies was using AI technology to figure out just by, so they were using the technology to build up a sensor in your car. So when you take a seat in the driver's seat and sit on it for about 5 minutes, it will sense the amount of weight you have, as well as the warmth and everything else, and give out glucose readings, give out your body temperature and everything else. Yes. And it would flash up on your monitor. And I think Tesla was working with them. So that was a AI system. I was thinking and wondering, wow, where is this going to end? And now it's beginning to take over our world. So I won't be surprised if that does happen in the future.
Yeah, it could be. Another question? Okay, thank you, Dr. Suhail. Another? Okay, one question there.
My name is Huda. I just have a question of the Ozempic. Said really good things about it, but I'm wondering, does it have any side effects? Because I know it's still new. And like with the 10% of the body, which is a lot, do you think maybe there are like side effects longer? The same way like with bariatric surgery, there will be side effects, or they will gain all the way back, these patients with type 2 diabetes.
Yeah, thank you very much for the question. Very relevant question, actually. So the GLP-1 analogs have been around since 2013. So we have about 10 years data. Ozempic itself has been around since 2018, mainly. And we have 5 years data now. So we don't have any major side effects. Initially, it was pancreatitis. And we realized that, the data we had, it never really caused pancreatitis. So you have causation and association. You have to bear that in mind. So it was associated with pancreatitis, but didn't cause it. And then you had the pancreatic malignancy, which was a scare, but that doesn't seem to have come true as well. Now you have the MTC, the medullary thyroid cancer screening. There's a red label against it. The FDA has mentioned that anybody with MTC shouldn't be given this drug. We don't have enough evidence to say it's causing it or associated with it. We will find out hopefully in the next 5-10 years when we have the data. So there are no red signals, I would say. These are useful drugs. They help you lose weight. They help you lower your glucose. They help you protect your heart. So I'm a big fan of these medications. And anybody who needs to take it or indicated to have it, then they should be prescribed this early in their journey of diabetes. The next part of the question, what happens if you stop them? My clinical experience is you begin to gain weight. Not all the weight that you've lost, but you do gain weight. So the bottom line is you need to work on their lifestyles. There's no point in dropping a medication and telling them that this is the magic pill. I think it's unfair on us. You know, when we talk about medicine world, we always talk about how I'm okay if I don't do any good to you, but I can't do any harm to you. And that's a message I always keep saying. This is not a magic pill. You need to sort out your habits, and this is going to help you long term. Hope that answers the question.
Okay, thank you, Dr. Sahel.